Hi, my name is David. I'm a second-year medical student performing a respiratory physical exam. But before starting the exam, I'm asking the patient for consent. After I get the consent, I will be looking at the patient's appearance and noting any use of accessory muscles, such as a well-defined sternocleidomastoid or trapezius muscles, and I do not see that there. The patient isn't gasping for air in a tripod position. While doing that, I'm also looking for an equal chest rise and just looking if the patient is in any sort of distress whatsoever. After that is done, I will be checking for central cyanosis and peripheral cyanosis. I will ask the patient to pick up his hands while I will be performing a capillary refill test. After that is normal, I'm making sure that there is no bluing around the fingers and around the palms, which rules out central cyanosis and peripheral cyanosis. Next, I will be asking the patient to look up while I look at the conjunctiva and rule out any pallor, which would be indicative of anemia. After that, I will take my pen light and look inside the oral mucosa and rule out any sorts of central cyanosis in that area, and nothing was present there. After that, I will be performing a clubbing exam. The clubbing exam is used to detect for chronic arterial hypoxemia, and I do not see any abnormal curvature of the nail beds there, which is normal. After that, I will be checking for a radial pulse for 30 seconds while also assessing for the patient's breathing pattern, measuring the rate, rhythm, depth, effort of the breathing, which was normal. After that, I will be checking for pitting edema at the tibial bone, which comes back unremarkable. After that, I will ask the patient to move to their left while I'll be assessing the posterior chest, looking for any scarring, any bruising before I palpate and identify tender areas around all the areas of the back with my finger pads in a circular motion. After that is complete, I will ask the patient to move forward and put his arms on his chest while I start at the C7, which is the most prominent area of the vertebra, and count down to T10 and assess for a chest wall expansion. And once I get to the T10 region, I will put my both arms, pulling the skin midline and asking the patient to take a deep breath while I appreciate symmetry of about 2 centimeters on each side, which comes back normally. After performing that exam, I will be performing the diaphragmatic exertion movement test. I will start at the midline of the lung field and move down until I feel for dullness, and I will mark that area with my marker. I will then ask the patient to exhale. After this, I will now ask the patient to exhale and hold while I start from the midline again of the lung field and move down, and also assess when I feel for dullness, and I'll mark it there. Normal movement, it's about 5 to 6 centimeters. If it were to be decreased, that would indicate phrenic nerve paralysis, atelectasis, or pleural effusion. I will then move on to percussions, which will help me to identify underlying tissues that are either filled with fluid or solid. I will be percussing and hearing for resonance, which is normal. If hyperresonance were present, that would be indicative of emphysema and dullness for the liver. After performing that exam, I will be performing an auscultation exam, listening to all the lung fields, listening for sound symmetry in all the 14 posterior locations. I'll be listening for normal breath sounds like inspiratory and expiratory lung sounds, also assessing if there's any abnormalities, such as wheezing, which is known for bronchoconstriction, any sorts of rhonchi, which would be present in any sorts of pulmonary edema, or inspiratory stridor, which would be present in epiglottitis. I'm also making sure that I can hear any breath sounds, and if it were to be abnormal, absent, or decreased, it can also be indicative of a pneumothorax or a atelectasis. I will be now performing a egophony and bronchophony examination, and this is helpful for noticing any transmitted voice sounds. I will be asking the patient to say 99 while I listen to the lung fields. And if I were to hear it clear, that would be indicative of a pulmonary consolidation. Now I'll be performing an egophony exam. I will be asking the patient to say E. While also doing that, I'm asking the patient to say 1, 2, 3, whispering, and that would be known as a pectoral exam. After that, I'm asking the patient to move back while I check for the trachea, make sure it's midline and not deviated away. That can be indicative of a tension pneumothorax or a spontaneous pneumothorax. After that, I'll ask the patient to lie down, and I will be assessing for the anterior chest. I'm doing the same thing with the anterior chest, also looking for any sorts of bruising, discoloration, scarring, pectus excavatum or pectus carinatum, which would be indicative of Marfan syndrome. Now I'll be starting at the jugular notch, moving down to the sternal angle. I'll be moving down to the 10th rib and also performing the chest wall expansion exam at the anterior portion of the chest. I will be counting down to the 10th rib as said and performing this examination, moving my 2 hands to the midline and asking the patient to take a deep breath, appreciating symmetry of about 2 centimeters on both sides. After that examination, I will be performing a tactile fremitus exam. I will be putting my arms at the ulnar side of my arms, placing it at the chest, and ask the patient to say 99 as I move throughout all the fields of the lung, of the anterior portion of the chest. After this is done, I will now be percussing in also all the fields, starting at the supraclavicular region, also percussing and feeling for resonance except cardiac dullness in the 3rd, 4th, and 5th intercostal spaces, 6 centimeters laterally to the left sternum. After this percussion examination, I will then move on to the auscultation. I will be auscultating in 6 positions bilaterally, also ruling out any adventitious lung sounds, such as crackles, also known as rails, which would be indicative of pulmonary edema. I would be listening to wheezes, which would be indicative of bronchoconstriction, which is seen in asthma, as well as rhonchi, which can be seen in COPD. After finishing with the auscultation, I will now be performing the examination that will be ruling out transmitted voice sounds. I will be asking the patient to say 99 simultaneously and auscultate and listen if anything is heard louder and clearer, as well as then doing an egophony exam, asking the patient to say E if I were to hear A, or if I were to hear anything louder in the bronchophony examination, it would suggest pulmonary consolidation. Now, to finish this off with the correlation of findings, it's best to know that dullness, crackles, increased breath sounds, and increased tactile fremitus suggest consolidation, whereas dullness, decreased breath sounds, and decreased tactile fremitus suggest for pleural effusion, and obstructive lung disease's physical signs would be a barrel chest, whereas we mentioned before a patient's AP diameter was normal, a decreased chest expansion, use of accessory muscle uses, cyanosis, and diminished diaphoretic exertion. And this is the end of the pulmonary examination. Thank you.